If PLAB 2 feels like a mysterious maze of buzzers, mannequins, and actors, just breathe. By the end of this video, you'll know exactly what happens, how you're scored, and how to play each station like a calm, safe FY2 doctor. PLAB 2, what is it, how it runs, and how to pass without losing your cool. PLAB 2 is a clinical OSCE, 16 scenarios, each 8 minutes long, designed to mirror real UK practice. Think GP rooms, emergency department cubicles, ward bays. Between stations you get 1 minute and 30 seconds to move and read the task outside the door. You also hear a warning buzzer at 6 minutes and a final bell at 8 minutes. Examiners watch, they almost never intervene. Actors play every patient. Your job is to be a safe, kind, and focused doctor. Where is it held? It's held in Manchester, UK. When does it run? The centre operates from Monday to Friday, and exam days typically have 2 circuits, one in the morning and one in the afternoon. Each station is marked across 3 domains: data gathering, clinical management, and interpersonal skills. 4 marks are awarded in each domain, so that gives you a total of 12 marks. To pass, you must meet or exceed the overall minimum score. These are added scores of each of the stations in the exam, and pass a minimum number of stations. This minimum is now exam specific, not a fixed 10 like it was before November 2024. If your total beats the pass mark, but you don't meet the minimum stations pass, or vice versa, you don't pass overall. So math check, 16 stations, each with 12 marks, so that means there's a total of 192 marks. Imagine the day's overall pass mark is 100, and the minimum stations to pass for the exam is 10. Score 99 with 13 stations passed, you fail the exam. You score below the overall cut. Score 120 with 9 stations passed, you again fail. You didn't meet the minimum stations. Both of these conditions must be met in order for you to pass the exam. Outside the station, you're given 90 seconds. Read the brief, read the patient's name, the age of the patient, the setting. Is this a GP clinic? Is this an emergency department? Is it a ward? And also read your task. These details drive safe management. Don't plan a hospital admission if you're in a GP clinic. Don't refer to hospital if you're already in the emergency department. Inside, you have 8 minutes. Bells ring, you're in. Work with the actor, run your plan, and listen for the 6-minute buzzer
2 minutes
to start
remaining.
wrapping up. Once this buzzer goes, you just want to start summarizing, safety netting, giving a plan. Once the final bell rings,
Move
there's
on to
nothing
the
you can
next
do.
station.
Nothing else counts. You won't have a visible timer in your room. The bells are your anchors. History taking, diagnosis and management stations. These are the bread and butter of the exam. These are the ones that you're going to definitely face. Expect a classical complaint of chest pain, shortness of breath, abdominal pain, and you're going to take a full history, and then after that examine the patient and then think of your management plan. One pro tip is when you enter the room, is there a mannequin? Is there equipment? What do you need to do? That's your first clue if you need to examine the patient. Prioritize red flags. Think about weight loss, night sweats, all these things need to come into play. And don't forget ideas, concerns, expectations. And lastly, don't forget to safety net the patient. Now, the next big stations are the counseling and the follow-up stations. These could be anything to do with contraception options or starting insulin or inhaler techniques or post-MI medications. The idea here is have a good structure. Check baseline knowledge of the patient. Explain in simple terms. Check the patient's understanding. Ask if they're still with you. And then make a shared decision on what you're going to do next. And lastly, don't forget to safety net as well. Now, ethics and communication stations, these are really important. You're going to be running through ethics like capacity, confidentiality, safeguarding. You could get an angry relative, or perhaps maybe a mistake or near miss, or it could be a breaking bad news station. These are all important topics. The next big type of station is the prescription station. These are drug charts. There is no patient there. It's just you and the drug chart with an examiner observing. There is no history in the stations. Start filling in the drug chart. You want to check allergies, renal function, VTE risk and prophylaxis, antibiotic choices and dosing. There is a BNF in the room, but let's be frank, you probably don't have time to use it. And then you have the SIMMEN stations. These are ones that you have a high fidelity mannequin in the room and the monitor. If you do something right, the observations improve. Expect to be doing ABCDEs, airways, breathing, circulation, disability, exposure, call for help early if needs be, give oxygen if indicated, gain IV access, consider fluids. These are things that you can think about. Think about glucose testing, ECG. You could get cases like sepsis or anaphylaxis, acute coronary syndrome, or asthma. These are all possible cases. Think of the ways you're going to manage this and some things to avoid. For example, you don't want to say, I will give the patient adrenaline. Don't say that. You might want to say something like this. I'm giving you 500 micrograms of adrenaline, which involves inserting a needle into your thigh, right? So speak to the patient, not the examiner. Be very specific with your management. Procedure stations, these are also very important. Think of catheterization, venipunctures, cannulations, arterial blood, midstream urines, peak flows, inhaler techniques. These are some of them that you'd expect to see that I would hope you'll be able to perform. Then you have your teaching stations. There is no history here. It will be you teaching a patient or perhaps even a colleague. You might be teaching a patient how to use an EpiPen, or you might be doing a S-bar handover to one of your colleagues, or teaching them something to do with asthma. Keep it interactive, check understanding. Ask if they understand what you mean by whatever you're explaining. Invite questions. Now, the whole circuit is a mix of all these stations. It's going to be predominantly the first type of stations where you take a history, you examine, and then you manage the patient. Now, who you're going to see are actors. They're not real patients. Treat them as real patients. Don't look at the examiner for help. The examiner is supposed to be invisible. They're quiet observers and they don't intervene unless they need to. You can't bring things that you can write on. Equipment is provided where needed. Let's talk about rest stations. You rotate through 16 stations and at least 2 of them will be rest stations. So you have 18 doors in total. Where your rest falls depends on where you start in the queue. Forgetting to name yourself and forgetting to check the identity of the patient. You should start like this. Hello, I'm Dr. So-and-so, one of your doctors today. Could I check your name and date of birth? Another pitfall is not reading the room. If there's a mannequin, equipment, or a clipboard in the room, you want to use them. Timing is key. My advice here is when you start practicing with your fellow colleagues, use a timer and visualize it. When you get better, stop visualizing the timer, but use the warning bell at 6
2
minutes as your
remaining.
guide. You want to pivot and start summarizing and start talking about your management and also safety netting. I generally start the management plan way before 5 minutes into the station. Always close with what to do if blah 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 happens and who to contact. Not asking for help is a problem. Especially in a SIMMEN station, you want to escalate early. Safe juniors call their seniors. What the examiner wants to see is a calm FY2 doctor who prioritizes life-threatening conditions and thinks about red flags, explains clearly, checks the patient's understanding, involves the patient, also prescribes safely and completely. And of course, they want an FY2 doctor that knows how to reach out for help, when to contact a senior. It's not perfect medicine, it's safe medicine. The marking model is literally built to reward that. the exam's intense, but it's also predictable. You march through 18 doors, meet 16 problems along the way, and you'll be able to do them if you practice hard. So find a few friends to start practicing with and keep practicing until you get there. You've got this.